ahead.
Good morning. It is my pleasure to introduce Dr. William George Ondo. He is the Director of Movement Disorders, Houston Methodist Hospital, and also Professor of Well Cornell Medical School, Houston, Texas. Dr. Ondo he undertook a movement disorders fellowship with Dr. Jankovic and joined the Baylor faculty for 19 years. Then later was a professor at the University of Texas Medical Science Center, Houston, for 4 years. He is a member of multiple professional associations and research groups, and he was the president of the Tremor Research Group from 2013 to 2020, for 4 years. 2014. Member of multiple professional associations and research groups, and he was the president of the Tremor Research Group. He has authored more than 275 original articles, review articles, and book chapters, and he has participated in more than 100 clinical trials in Parkinson's disease, tremor, restless leg syndrome, dystonia, Huntington's disease, and other movement disorders. His current research interests include Parkinson's disease, restless leg syndrome, tremor, and the use of botulinum toxin. So I invite Dr. William to deliver his lecture on restless leg syndrome. Dr. William, please.
Okay, so hello. I'd like to thank the sponsors for the invitation here. It's late Saturday night in Texas, and I guess Sunday morning throughout India. This is going to be a fairly in-depth presentation on restless legs. I think it'll probably take a whole hour. I'm going to emphasize a bit more pathophysiology than you might be used to hearing because, to make the point, there is actually quite a bit of pathophysiology that we understand in RLS, although certainly we don't understand everything. So with that being said, we'll start with a little bit of the clinical aspects of RLS. RLS is defined by subjective report. There is no test for RLS. There is actually no objective finding in restless leg syndrome. You have to have four things. You have to have an urge to move the legs. Now, this may or may not have some sort of paresthesia or sensation, but no matter what they say as far as the sensation, it has to be associated with some feeling of movement or need to move. So pure pain is not restless leg syndrome. Number 2 and 3 are related. Symptoms have to be worse with inactivity and then improve transiently with activity. So anyone with RLS can tell you they get up, they walk around, they bicycle, they kick, they do things like this to feel better. But even intense cognitive activity can improve RLS. So a legitimate argument will actually improve restless legs. An intense concentration can improve restless legs. So a video game that requires concentration can improve this. Unfortunately, watching TV, reading, things like that don't improve restless leg syndrome. And then finally, there's a true circadian pattern to RLS. It's worse in the evening and night, and probably most robustly, it's improved in the morning. From like 6 a.m. to noon, very unusual to get RLS unless patients are augmented, which we'll talk about later in the lecture. And that's it. It's an urge to move the legs. It's worse with inactivity. It's transiently better with activity. It is worse in the evening, better in the morning. If you have those things, you have restless leg syndrome. Now, there are a number of other supportive criteria that go along with this, and we're just going to talk about a couple of these. We'll talk about periodic limb movements of sleep. We'll talk about the genetics and the pathophysiology. It is a very robustly genetic condition. And then dopaminergic response. I mean, the initial response to dopaminergics is very, very robust in patients with RLS. And again, it's supportive from a diagnostic standpoint. Okay, now, very few people quote NIH criteria for restless leg syndrome. So this was a study I did as a fellow back in 95, 96, just descriptions of RLS, and it basically the words people use. Now, again, the key is not to get caught up in the semantics. This is going to vary depending on where you are. But again, number one is just this complaint is I just have to move my legs. And you get this crawling, creeping, pulling, electric sensation. Pain is on this list, but again, I want to emphasize that isolated leg pain by itself without an urge to move is not restless leg. So again, don't get caught up too much on the way it's described. As long as you turn that around, do those, Elvis legs make you want to move, do they make you want to move your legs? The answer has to be yes. few other phenotypic issues. It's typically the most common is sort of the calves, okay, behind the knees, calves. Isolated foot involvement is very, very rare. So patients don't want to wiggle their toes. They want to flex their hip, their knee, and their ankle in order to improve sensation. So again, different than neuropathy, which would most likely initially affect the feet. Likewise, it's a deep sensation. Almost always they say it's deep. It's in my bones, it's my muscle. It's not superficial, again, like a painful neuropathy might be. It's almost always bilateral to some extent, but on any one night, the left leg may be worse, the right leg may be worse. It very frequently alternates, patients will say. Arm involvement, not rare, but typically after many years of leg involvement. So again, isolated arm involvement. There have been a few case reports here and there, but extremely rare to have restless arms without having concurrent restless legs. And then finally, the periodic limb movements of sleep. So this is a polysomnogram, and this is just EMG activity in the anterior tib in this case. And you can see, I'm not sure the time course here, this is pretty rapid, every 10 or 15 seconds. You'll see this EMG activity manifesting as a kick, and we'll talk about that just a little bit more. Now, one of the interesting things about the periodic movements of sleep is that there is somewhat mixed, but a fair amount of evidence to support an association between these leg kicks and then cardiovascular disease. So again, there's a little bit of mixed data on this. There was just another publication just a month ago or so, which I don't have listed on here yet, showing that there was an association. One of the interesting things about the leg kicking, the periodic movements of sleep, is when that happens, there's an acute spike in blood pressure. Systolic blood pressure goes up 15 to 20 points and diastolic up 10. And this happens, 100 times a night. And that's thought to potentially explain this association with cardiovascular disease. What's not known is if treating those periodic movements of sleep reduces the risk of cardiovascular disease later in life. Okay, so I did not do that. All right, so let's show one or two videos. Okay, so hopefully I'm set now. Okay, so this is someone typically with restless leg syndrome that you might see later in the afternoon. So again, if they come to your clinic in the morning, you're really not going to see this. It is suppressible. If I said, hey, you're moving your feet, the patient would be able to suppress it or stop it. But they don't know, we're just talking about something else distracting them. And you get these stereotypy type movements. So this is pretty common in patients with restless leg syndrome. Now, in someone with very, very severe restless leg syndrome, you might get, something which really looks quite dramatic. So this is a woman, we've asked her just to try to sit down as long as you can. And you can see how difficult it is. Or, she's stretching, moving her legs because it's just an extremely unpleasant sensation, making her want to move the legs. And eventually, stretching, these are all the things patients do to try to get relief. And then eventually she'll give up and get up and walk around. So this is someone with severe restless legs. And you can imagine something like this can be misdiagnosed, even as dystonia, chorea, these sorts of things. So finally gets up, walks around, and you get some relief while walking. So a case of very severe restless leg syndrome. Now, the periodic movements of sleep I mentioned, this is this sort of triple flexion response kicking that you get. This person is asleep, so there's a polysomnogram that's showing this. And again, there is this rhythmicity to this, and there's certain criteria that you use to make periodic movements of sleep. The interesting thing is what's the relationship between POMS and RLS. I mean, almost everyone with RLS has POMS, but there are many people that have POMS that would be picked up on a polysomnogram that don't have RLS. So you don't need a polysomnogram to make a diagnosis of RLS. It really isn't part of the diagnostic criteria at all. Now, sometimes you can get this while awake. And again, these tend to be more severe cases or patients that are augmented. Again, getting to that in a little bit. But this is the same sort of thing, but this patient is obviously awake. And this is, variably suppressible. In some cases, this is not suppressible at all. In other cases, they might be able to hold still a little bit. But this can get quite, again, in a small number of patients. You don't see this that often, where you get these severe periodic limb movements while awake. But we think of it as the same pathophysiology that's going on. And this actually goes on for a couple of minutes, and they crescendo in amplitude when she's lying down. So you see even the torso goes a little bit, the arms go a little bit, and then you can get a larger amplitude than that. All right, so I'll give it 5 or 10 more seconds, see if we get one more jerk. But again, now she's obviously wide awake, and she'll get these periodic limits. Now, this also looks kind of weird. You might think this might look like a functional or psychogenic movement disorder, but again, very physiologic. And when we treated her, this resolved. Okay. So the differential diagnosis of RLS, you can come up with a decent list of differential diagnoses, but really with just a careful history, you should be able to sort this out. The closest thing is akathisia. So the difference in akathisia is it's a whole body need to move, and it's not necessarily worse at nighttime. And akathisia, of course, usually associated with dopamine blocking medications. Painful legs, moving toes, really nothing like RLS, the foot, writhing toe movements. Leg cramps, again, it's not really anything like RLS, but patients may just say, my legs feel crampy at night, and you think they have common leg cramps, which is a chaotic, involuntary muscle contraction. So again, restless legs doesn't have rock hard muscles like a leg cramp. You can't break it after 30 seconds or something like this. The most interesting one I think I ever saw that came to me with a misdiagnosis was someone that came to me with a diagnosis of restless legs because they couldn't stand still, and they always had to walk around, but they actually had orthostatic tremor, which is a very uncomfortable sensation when you're standing, which improves immediately on walking. So that was kind of an interesting case many years ago. So I mentioned akathisia. Again, akathisia is a subjective condition, but you tend to get this sort of rocking movements in someone with akathisia. And this is someone that got some droperidol for migraine. Droperidol is a dopamine antagonist medication. And she's just antsy. I mean, she just, can't sit still, very unpleasant, but it's her whole body and it's there all day. It's not worse at night. Okay. So the phenotype in children is interesting. Some kids will meet diagnostic criteria for restless legs, but the official criteria is a lot looser. They may have just growing pain complaint. An interesting thing about RLS in children is an association between RLS and attention deficit disorder. So these are some studies, and a couple of these are kind of old, but I think they're still relevant. If you take kids with ADHD, okay, diagnosed with ADHD, just to an ADHD clinic, if you do sleep studies, many of them will have periodic limits of sleep. So kids do not get periodic limits of sleep. It's pretty common in adults and older people, but children don't get it normally, and a quarter of them had PLMS. Perhaps most striking, a third of these kids, and this was just an unselected group of ADHD, a third of them had a parent that had met criteria for restless leg syndrome. So again, and that's some of these parents are in their 30s or 40s, so that probably is going to go up with time. Also, there's been a long, old literature on low iron in ADHD, and again, we'll talk about iron here in more detail when we get to the physiology of restless legs. All right, so how common is this? Well, it's a pretty common condition. Now, this is predominantly European. It seems to be most common in Scandinavian countries, where it could be 15, 18% of the population has it. Anglo-Saxon, Germanic are next most common. And then as you get Mediterranean, and then you go farther south and farther east, it seems to be less common. There have been a couple of decent studies in India suggesting about a 2% prevalence of RLS in India. So again, just makes the point that different countries, the more north you are, basically, the higher the frequency, the prevalence of restless leg syndrome. Okay, so let's get into pathophysiology a bit here. We'll talk about genetics, some farming animal model stuff that we did years ago, and of course, just pathology. So genetics, this is a very strongly genetic condition. The first stab at genetics, monozygotic twins, shows very high concordance rates and a higher concordance rate in monozygotic than dizygotic twins. So we have that initially. Now, there have been many linkages, about 18 or so, if I recall, linkage studies, which we don't do that much these days. But there has not been an actual gene identified through those techniques that causes RLS. And that being said, in GWAS studies, there's a whole slew of genes that pop out. There's 19 published, but there's actually about 70 more in a very large study that hasn't been published yet. So we have a large number of GWAS. So again, GWAS studies are a little bit controversial. in their utility, but that this is a list of the published genes, which came out of mostly out of a large collaborative effort run in Germany, but with RLS patients from all over the world. So, obviously you're not going to memorize these. What do these genes do? That's sort of the clue here. Well, first of all, they're mostly in the brain. Many of them are in development. So knocking out some of these genes will result in abnormal neurodevelopment. And not surprisingly, based on the response to meds, many of them are synaptic axon formation. So they control guidance of synapses. A few of them are DNA repair. That's not, I'm not sure if that's specific to RLS or not. But again, we're getting a better understanding based on genetic studies. But right now, there's no reason to do genetic testing. You can actually get some genetic tests. I think 23andMe, for example, has 2 of the genes. But again, these are just normal alleles. They're not mutants. They're genes that many patients have that confer a modest increased risk for developing restless leg syndrome. Okay, so it's very genetic. It's polygenetic. There's no single gene that determines yes or no you get restless legs, at least that we know of so far. There's no reason to be genetically tested, but again, it is a launching point for further investigation into RLS. Okay, what about some animal models? Show this because we've played around with this, although it's been a little while these days. What are the clues? Okay, the clues: legs more than arms. So that screams out spinal cord, right? Dopamine, okay, we'll see the dopamine response is very dramatic. So there's some sort of dopaminergic connection to this. It's some sort of anti-nociceptive component, okay? I mean, it's a sensation that's just being made up by the brain. And then there's a strong circadian component. So it has to be near circadian control centers. We looked at that years ago and we came up with this little area called the A11 or diencephalic spinal tract. It's a small area. Most people have never heard of it. It's dopamine neurons that go all the way down to the spinal cord. They have axons that are 1 meter long. And the little that's known about them had to do with anti-nociception and autonomic function. So maybe that systolic blood pressure issue with the periodic limits of sleep. Anyway, we've played around with mice and rats. We made lesions. Again, it's a very small area. We're talking just thousands of neurons, not hundreds of thousands. And basically when we did this, and especially then when we iron deprived the mice, we made hyperactive mice. So this is the group with the model, and this is a sham control group. And again, this has been highly quantified, and they get up, they move more, they're antsy. I don't know if they have the heebie-jeebies, but as far as we can tell, it's consistent. So again, this is quantification of the movement. So the model is in black, and you can see much more movement than can sham, and just iron deprived or just lesions. So to get the full phenotype, you need to iron deprive them and make these dopamine lesions. These rats are also very angry. They became quite violent. Ornery would be the Texas word that we would use for this. And just to break up the lecture, I show some rat violence of one attacking the other. The handlers were quite happy when they got to sacrifice these mice because they kept getting bit. So we made sort of hyperactive, angry mice with a very small lesion. Now, the interesting thing about this, when you treat it with dopaminergic medications, they got much better. If you gave them dopamine antagonists, they got much worse. But very interesting, if you gave a D1 specific agonist, okay, they got worse too. So a D2, D3 made them better. A D1 agonist made them worse. And we have pursued that with clinical trials, which have not been published as a sort of potential pathophysiology in the spinal cord. Okay, move to people. You could do any sort of test you want on a person. You're really not going to find very much with standard physiologic and imaging tests. Now, that's not to say there aren't potential subtle abnormalities. There have been a number of studies looking at MRIs in patients with RLS. Probably the most compelling data is that there's the pulvinar gray volume, so in the thalamus, seem to be a little bit bigger. Now, this is nothing you can see on an individual patient. It's about 10, 20% bigger. So again, there's no utility in this clinically, but it's kind of interesting, especially when we get to pathophysiology here in a bit. Functional MRI shows that there seems to be increased activity in the thalamus, cerebellum, and in another study in the brainstem, consistent with the olivary nucleus. So that's like Mollaret's triangle, which is also seems to be involved with essential tremor. So again, there's increased activity in the brainstem, cerebellum, and thalamus in patients with RLS. Well, what about dopamine? So we're going to talk about dopamine treatments in a bit. If you do imaging studies, you really don't get any consistent results. Now, the big caveat here is these imaging studies all look at the substantia nigra and striatum. And we have reason to think that that area of the brain is not really involved with RLS, that it's a very much smaller dopaminergic area that really is far too small for these imaging to pick up. So, these dopamine systems still may be involved, but if you do, again, these standard like fluorodopa PET, raclopride PETs, you really don't see very consistent results. You could actually argue about these results for a couple of hours, but suffice to say, there's no overt evidence of dopamine dysfunction. Okay, so what is abnormal? Well, this is where we get to iron. So this is an MRI, which is T2 prime, which is configured to show iron and white. This is a control on the screen right, and versus a patient with RLS. And of course, that is not a subtle finding. Patients with RLS have a marked reduction in brain iron compared to age-matched controls. This has been shown in, I think, 25 out of 26 studies now that have looked at a variety of ways of looking at iron. This is ultrasound. And again, you show a marked reduction in brain iron in patients with RLS. Well, let's look to the brain. First thing we did was look at dopamine areas, and we could not find any abnormalities in dopamine cells, including the A11 cell. So it did not seem to be a neurodegenerative disease. In fact, if anything, they had about 10% more dopamine cells overall than control. So it does not seem to be similar to Parkinson's disease in that you lose dopamine cells. Okay, what we did find, consistent with the imaging, is a reduction in brain iron. So again, these are H-ferritin, L-ferritin stains. Just quantify this with some graphs. And this was the very first study. It's been replicated. Essentially, every measure of iron in the brain, so this is brain tissue, not blood iron, brain tissue is abnormal in patients with RLS. Transferrin in the brain, again, this is not blood, this is brain tissue, is elevated as you would expect, but here's where it gets complicated. If you have just iron deficiency, you should have a marked increase in transferrin receptor. It's a very sensitive measure. In fact, it's probably the best test for iron deficiency. But in RLS, the transferrin receptor is actually decreased. So this suggests that there's something internal in the brain cells that's abnormal that does not want the iron. It's not just they can't get the iron to the brain cells. They don't want it. There's some abnormality and they're spitting it out by downregulating transferrin receptors, which are one of the main ways that iron enters the cell. Now, again, this could go on for another couple of hours, but really we don't have a great understanding of why that is. No one has found a genetic abnormality in transferrin receptors or anything like that. One of the interesting hypotheses is something called Thi1. Thi1 is very much involved with the release of dopamine and to some extent other monoamines. And it turns out that when you iron deprive an animal, you reduce the active component of Thi1. And if you look at Thi1 in RLS brains, you see that it is also reduced. And this actually makes a lot of sense. This is really touchy because if you had a reduction in Thi1, it would mean you would have a normal amount of dopamine, you would have normal dopamine receptors, but you can't get the dopamine to the dopamine receptors, the transportation of it, because it's not released. Thi1 is necessary for the release of dopamine presynaptically. So I've always liked this hypothesis, but that's still what it is. And this has been around for a while now, but no one has been able to prove or disprove this. Now, there are other abnormalities. Again, there's actually quite a few other abnormalities, but for the sake of time, I'm just going to hit a couple of the important ones. If you look at endorphin and enkephalin staining in RLS patients, you will see that the number of cells that stain positive for enkephalin and endorphin is reduced in the thalamus in patients with RLS. So Art Walters headed up this with an autopsy study that we contributed to. So there seems to be a reduction in endogenous enkephalins and endorphins, so pain suppressant components. Another interesting thing is orexin abnormalities. So orexin is very much involved in sleep-wake cycling. So patients with narcolepsy have antibodies and autoimmune reaction where they reduce orexin cells. And when you have reduced CNS orexin, the sleep switch between sleep and wake just flips back and forth much more rapidly. And in general, patients fall asleep much more. Now, patients with early RLS, this is what we think of sort of the truest RLS. These tend to be genetic RLS, okay? They actually have reduced orexin compared to controls and compared to patients that get RLS much later in life. And that goes along with clinically, because RLS patients can be severely sleep deprived, but they don't fall asleep during the day. They don't nap. Now, some of that's because whenever they try to nap, the RLS kicks in and wakes them up. But again, if you have high orexin, you would have less ability to fall asleep during the daytime, okay? So there's quite a bit more in pathophysiology, but for the sake of time, I think those are the highlights to make the point that there is a bunch of pathology in RLS. So let's talk about some associated conditions. I'll spend just a few minutes on this as well, because there are a number of other things that can cause, that are at least associated with RLS. I don't want to say cause because we don't know, it's just an association. So we'll talk about systemic iron deficiency. We already talked about, you know, the main brain pathology on autopsy is reduced brain iron deficiency, even in the setting of normal serum iron. But if you're systemically iron deficient, you could have RLS. We'll talk briefly about kidney failure, pregnancy, MS, and maybe tremor and Parkinson's, just one slide each. So this is an EM of a ferritin molecule. Ferritin molecule is pretty cool, one of the larger proteins in the body. It's a giant hollow ball. It can store about 2,000 atoms of iron, and it's the main storage iron. H-ferritin is a more active storage, and L-ferritin is what's thought of as like deep storage. It's very difficult to access the iron in L-ferritin until you're like really life-threateningly iron deficient. So the problem with measuring iron in the blood is that there's no good test for iron. Ferritin is great if it's low. If it is low, you have iron deficiency. Now, what is low? Good question. Now, what the lab tells you is absolutely incorrect. Ferritin increases with age, and as I think a rule of thumb, if their ferritin is under their age, they are iron deficient. So it's not 10 or 20 or whatever the lab says. If ferritin is under their age, I would consider them iron deficient. Now the problem is ferritin that's normal or high can mean anything because it's acute phase reactive. So if someone has arthritis, their ferritin goes up, okay? Certainly in kidney disease, ferritin goes up. So a high normal ferritin tells you nothing, but a low ferritin tells you they are iron deficient. So another thing that we use is iron binding percentage, and this is a formula. It seems it's less data on iron binding percentage, but very frequently in older people, you'll see a low iron binding percentage and a high ferritin. To me, that also means they're iron deficient. Yeah, the iron itself is worthless because it goes up and down 50% across the day. Right after a meal, it spikes. So again, that's a useless test, except that it's part of the formula for iron binding percentage. Okay, so not a straightforward thing to assess systemic iron deficiency. Now, that being said, when we have taken large number of patients and just looked at ferritin, we found a couple of interesting things. So RLS can be divided sort of a couple ways: late onset versus early onset, and the arbitrary cutoff is 45. But very frequently, there's a big group that gets in their 20s and 30s, and then another big group that gets in their 60s and 70s. Although there's plenty of people that get in their 40s or 50s as well. But nevertheless, if you make this dichotomous, if you take patients with early onset restless legs, as a rule of thumb, they're much more likely to have a family history of RLS. Okay, very likely to have a family history. In these patients, if you measure serum ferritin, you really don't see much. It seems to be about the same as controls, and it doesn't correlate with severity of disease. However, if you take this group that has later onset RLS and they tend not to have a family history, believe me, there's plenty of exceptions here, but as a rule of thumb, they don't have a family history. These patients do have a correlation. So low serum ferritin seems to be a risk factor for developing RLS later in life, even if you don't have a family history. So that probably is a secondary association with RLS. So the one test that every RLS patient gets is a couple, the iron test. You could argue that's the only test anyone needs with restless legs, unless there's something else suggestive that you should get a test for that, sleep apnea, neuropathy on examination, something like that. Okay, kidney disease. Patients on dialysis have terrible RLS. It's probably about 30% of patients on dialysis have RLS, and patients with renal failure without dialysis, probably it's about 15 to 20%. So it occurs before the dialysis. And if you look at these patients, do sleep studies, they'll have terrible leg kicking, 119 an hour as the mean. That's just a crazy number. RLS with uremia does not get better with dialysis. In fact, if anything, there's an inverse correlation. The more dialysis, the worse the RLS. And it does predict mortality. There have been 4 studies now that looked at this, some of them at RLS, some of them periodic limits of sleep. And in the dialysis population, the number one, believe it or not, the number one predictor of mortality was the presence of either RLS or periodic limits of sleep. Now, you can argue about why that is, or cause and effect. But it's a pretty striking finding. The responses tend to be the same as with idiopathic RLS. We'll get to these next, but you often need higher doses for renal RLS, which really can be quite severe. Interestingly, it resolves with successful transplant. So there's something about the uremia itself that causes the RLS. It's just not the risk factors. They have diabetes or hypertension or whatever caused the renal failure. Once you have a successful transplant, pretty quickly, the RLS improves in most people. So again, that's the definitive treatment in this population. All right, neuropathy I alluded to. This is it's probably the most complicated thing to look at because neuropathy is so common. RLS is very common. And there's been a number of studies with a little bit of mixed data. In our study we did in patients with RLS, we broke it down this way. Positive family history, yes, of RLS. No family history of RLS. We did standard EMGs. And you can see the patients that had a family history, only 22% abnormal, but 71% abnormal if you didn't have a family history. And some of these may also had low iron. So you may have a double hit by deafferentation and low iron that results in RLS type symptoms. So again, it suggests that neuropathy may be a risk factor for RLS. Like I said, there is some mixed data on this. It's probably the weakest of these associations that we're talking about. But again, if they have evidence of neuropathy, I certainly would recommend working that up, looking for treatable causes of neuropathy. Keeping in mind a normal EMG doesn't absolutely mean you don't have neuropathy. There's at least one study which correlated RLS with small fiber neuropathy. And to make that diagnosis, you need to do a biopsy to make a diagnosis of this. So again, small fiber neuropathy has also been associated with RLS in at least one study. All right, going quickly, MS. Multiple sclerosis, a number of studies that have shown higher rates of RLS. In some of these that have looked at it fairly closely, interestingly enough, again, at least one of the good studies that has looked at this did show that there was a correlation between RLS and spinal cord lesions. There also seems to be more of a higher association with chronic progressive MS as opposed to relapsing remitting MS. But again, to me, the spinal cord is the more interesting finding because, again, it corroborates this pathology, we think. Pregnancy. This is one of the more interesting ones. In the best studies that looked at the best one by far is the Manconi study, probably about 5-10 years ago now. 27% of patients in their study developed RLS. People who have looked at this more carefully, this comes from the Manconi study. You can see the Italian there when you loaned me the slide. But again, this is your baseline. At this age, maybe 4% of people have RLS. And then it gets a little bit worse, but in the 3rd trimester, it spikes. And then strikingly, right after delivery, it improves. So the question is, why does this happen? I mean, what sort of clue is this? Well, the first idea was iron. I mean, because iron gets completely messed up during pregnancy. And again, iron tests in pregnancy are also worthless because the ferritin skyrockets. And then the next one was folate. So, I mean, everyone gets folate supplements now, hopefully, during pregnancy. I think the best data is for increased estradiol. There's actually only, this is a study that needs to be replicated. There's one small study of 10 patients. I think it had a p-value of 0.07 or 0.06 with just 10 patients that high estradiol levels correlate with RLS. And that makes sense because right after delivery, estradiol goes way down as the RLS improves. And estradiol does have some impact on dopaminergics, although it's not exactly clear. Anyway, RLS during pregnancy can be a big problem because obviously we don't have treatments that are absolutely established as safe that are approved for restless legs in pregnancy. All right, last couple of associations. Parkinson's, well, RLS is treated with dopaminergics. Parkinson's treated with dopaminergics. Is there association? Well, a lot of people have looked at this. I guess we were the first, but the second did come out of India. Christian, who's published several papers on RLS. And I don't expect you to memorize all these numbers. If you'll believe my gestalt, the vast majority of studies show that in Parkinson patients, there is a higher rate than would be expected of RLS, usually about double what you would expect. Now, various studies have looked at associations and things like this. And I think the bottom line is, to me, without trying to, again, you could spend obviously 2 hours on this slide alone, is that RLS is one of the many non-motor phenomena in Parkinson's disease. I do not think there is any compelling evidence that developing RLS later increases the risk for Parkinson's. It's the other way around. Parkinson's causes the restless legs. Is the physiology the same? Is the physiology different? We do not know. There's some interesting opposites about PD and RLS. I mean, RLS has low iron, PD has high iron. PD obviously has low dopamine. If anything, I didn't get into this, but RLS has increased dopamine turnover, although there's not an increased amount of dopamine. So there really is there's nothing pathophysiologically similar between RLS and Parkinson's, other than they both respond to dopaminergic medications. Last thing I want to touch on, very important. One of the maybe 2 or 3 most important points of this talk is iatrogenic RLS. The big one here is antihistamines. So sedating antihistamines, they're sedating because they cross the blood-brain barrier. So diphenhydramine is the classic one here. They can really exacerbate restless leg syndrome. And keep in mind, there's a lot of antihistamines out there. There's a lot of drugs with antihistamine properties. You know, things like amitriptyline, very powerful antihistamines. Basically, any drug that makes you sleepy, just almost, is an antihistamine. So they're not all just cold medicines, itching medicines, nausea medicines. These can all be antihistamines. So there's a huge list of antihistamines out there. And if someone has an acute exacerbation, that's one of my very first questions. I mean, we go through the meds, over-the-counter medicines also. Are there any sort of sedating antihistamines? So the non-sedating antihistamines, they basically don't cross the blood-brain barrier. They don't seem to be as big an issue. But again, this is probably the number one thing that exacerbates RLS. And this is very common in hospitals. I have some great vignettes, you know, someone getting knee surgery, they're in a bit of a cast, they're itching, they get an antihistamine for the itching, and they just go berserk because they can't move, and they were given this medicine that worsens the restless leg syndrome. So just keep that one in mind. Dopamine antagonists, of course, can worsen RLS. What's kind of interesting to me is that they don't always. You know, because dopamine agonists treat it, you would think dopamine antagonists always make it worse, but they don't, but can. And then antidepressants. So SSRIs clearly cause periodic movements of sleep. Very robust. Almost anyone on an SSRI, if you do a sleep study, will have greater than 10, usually about 20 periodic movements of sleep a night. I think there's much less compelling evidence that they worsen RLS. Now, keep in mind, many antihistamine, again, antidepressants are antihistamines. So again, amitriptyline, again, very strong antihistamine. So those sorts of antidepressants, sedating antidepressants, tend to worsen restless legs. Okay, so with that, we'll segue to the last part, talk about treatment of restless legs. I mean, fortunately, we have very good treatments of RLS. We'll spend most of our time on these first few, the dopaminergics, the gabapentin type drugs, opioids, and then we'll spend some time on iron as well. All right, first slide on treatment of RLS. This was a collection of data on pramipexole. RLS, most people use this 40-point scale. The average score on studies of RLS is about 26. This is the improvement, a mean 9.5 point improvement. That's a 35% improvement on placebo, okay? There's a very strong placebo response with restless legs, just as there is in Parkinson's disease. So until a study is a placebo-controlled study, take it with a grain of salt, because again, an open label study in RLS really doesn't mean very much. There are some interesting predictors of placebo response as well that we played around with this large database that Berner Ingelheim gave us. so that you could have some fun with. So Finland has the highest placebo response of any country if you're thinking of doing a drug trial. But again, until there's a placebo-controlled trial, I don't necessarily believe that it works. Okay, so first treatment, sensory stimulation, vibrating pads, heat, pressure pads. These sorts of things can help. I mean, if you have mild RLS, you have maybe 30 minutes a night in the evening, these sorts of things may be satisfactory. But when you get to more severe RLS, they're usually not satisfactory. So let's talk about dopaminergics first. Levodopa, no doubt that levodopa is effective for RLS. There's actually about 14 controlled trials now. Levodopa is approved in Germany and a few other countries as an official treatment for restless legs. Levodopa in RLS does not cause dyskinesia. It does not cause visual hallucinations, maybe very, very rarely, but nothing like Parkinson's disease. It doesn't seem to cause orthostatic hypotension. It's pretty rare to have any impulse control disorders with dopaminergics. Again, it does happen occasionally in RLS. So many of the adverse events you're used to with Parkinson's disease actually don't happen in restless legs. You can get nausea, sedation, things like that. But the big problem with levodopa and dopaminergics as a class is this concept of augmentation. Okay, so what is augmentation? Well, good question. There's a lot of different criteria for definitions of augmentation, but basically, you get improvement with the drug, but over time, and by time I can mean months to decades. So I've seen people 15, 20 years on fairly stable doses before they have bad augmentation. I've seen people for 6 months on doses before they start to have augmentation. So the key feature is earlier onset of symptoms. And again, there's some formal criteria, but it's arbitrary, of course. They have an earlier onset of symptoms. So for years, they had symptoms at 9 p.m. They took a dopaminergic at 8 p.m. They got rid of their symptoms. That worked for a few years. Now they have symptoms at 4 p.m. Okay, you can give them another dose at 3 p.m. and take care of that. And then a year later, they have symptoms at 10 a.m. Okay, so you push the onset of symptoms earlier. That's the key feature in augmentation. You have to have that for definition of augmentation. Then basically everything else gets worse. So you can get arm involvement. Okay, it doesn't improve when you walk around anymore. And of course, it gets more refractory to treatments. So this is the biggest problem with chronic therapy with the dopamine medications. People have looked at risk factors. The biggest one is duration of treatment. I'll show you some data on this, but it's pretty linear over time. Higher doses associated with augmentation, but again, this is potentially a circular argument because you sort of eke up on the dose, and patients with worse RLS require a higher dose, so maybe it's not cause and effect. One of our studies showed a family history of RLS and lack of neuropathy. So these tended to be the same patients. They were a risk factor for RLS. And there's a couple studies that show that low iron is a risk factor for RLS. So this is an argument to treat everyone aggressively with iron, even if they're doing pretty well, because you might make them better 10 years down the road. Maybe shorter acting dopaminergics, but that's a little more controversial. So these are risk factors for augmentation. Okay, now the dopamine agonists don't have nearly as much augmentation as levodopa, but they still have augmentation. This is the big advantage of dopamine agonists over levodopa, and the reason that we don't really use levodopa very often. I occasionally use levodopa as a PRN medication because it does kick in a little faster than oral dopamine agonists do. But again, we almost always use these three: ropinirole, pramipexole, rotigotine, which comes in a patch, as the main treatments. Pergolide is effective. Cabergoline is effective. They have more D1 properties, and at least hypothetically, you don't want that. There's no head-to-head data versus one dopamine. Well, I take that back. There is a little bit, but nothing prospective head-to-head data on dopamine agonists. But I think I would recommend any of these three. And if you put a gun to my head, I would probably say pramipexole is the most effective. But any one person, they may prefer ropinirole, they may prefer rotigotine. Okay. So amongst them, like I said, globally, the results are about the same. They all have big placebo response. Rotigotine in the US comes in a patch form, so you get 24-hour coverage. So in the studies, you had, I think, a higher percent of patients that went to 0 on their RLS scales. There are extended release versions of ropinirole and pramipexole, which are not approved for RLS, but they can be very effective, and we use those medicines as well, these extended release versions of the drugs. Now, these days, everyone bashes dopamine agonists because they work great at the beginning, but 5, 10, 15 years down the road, they cause this augmentation, which gets much more problematic to treat. That said, this is, one of the physiologic assessments of periodic luminance of sleep. Now, this is pramipexole. This is one of the very first pramipexole studies ever. You can see I took a picture of the article and then cut and paste that picture into my slides. It's that old. Placebo-controlled trial on placebo. They averaged 500 leg kicks a night. On pramipexole, I think it was 1.2. So I would challenge almost anyone to show me a graph in all of medicine that's more impressive than that. So it shows you the dramatic physiological response. Now, this is a higher dose. This was 0.75 and 1.5 milligrams, so a higher dose than we typically start people on for restless legs. But if you do those higher dose, the leg kicking, the motor component of RLS, again, it's not technically part of RLS, but it is. It's just dramatic how much you can reduce this. So what's the strategy with dopamine agonists? So a couple of things. The key is timing. So if you have a patch, 24-hour patch, the timing is not that important. But if you have a pill, you have to get, this is sort of important, hugely important point number 2. You have to get the medicine in the system before the onset of symptoms. It makes the world of difference. If they start to have symptoms and then they take the medicine, you need higher doses and you're sort of chasing it. And I've just, over the years, so many cases, all we did was move the dose 90 minutes earlier, and that took care of it. Okay, sometimes you could even lower the dose by taking it earlier. So everyone's individualized as timing. If they have symptoms right at bedtime, sure, take it 1 to 2 hours before bed. That's great. But if they have symptoms in the evening time, you have to get that first dose in the system prior to the onset of those symptoms. And if it requires a second dose of an oral medicine, so be it. So that is extremely important. The nice thing about these drugs is the effect is immediate. I mean, the first pill does what it's going to do. You don't have to take it for 3 weeks to see what's going to happen in someone with bad RLS. It's an immediate effect, so you can titrate these very easily. You go up, you start it on a tiny dose, you work your way up to the lowest dose that works, and you try to stay there as long as you can. Okay, so sometimes we have had some success rotating them around. No published data on that as well. All right, so next category, opioids. So for anyone to think that this is a recent disease, this is a description of RLS by Willis of London, of Circle of Willis fame in 1683. Describing RLS, called it soul of brutes. And I point this out here because he claimed to very successfully treat this with tincture of opium. So this is the first documented case report of restless legs and treatment of restless legs with something that we still use, 350 years later. So opioids. Obviously, certainly in many countries, there's been a huge backlash against opioids, for legitimate reasons. But opioids can be extremely effective in restless leg syndrome. They may treat the sensory component more than the motor component. A couple of sort of generalizations about them. They have to be mu opioid receptors, okay, and most of them are, but the kappa opioid receptors do not work for restless legs. The best studied by far is a combination of oxycodone and naloxone, which is again approved in many European countries through the EU officially approved study for our drug for restless leg syndrome. They tend to cause constipation, but, and this is both in published data and certainly anecdotally, rates of addiction and dependency, because those are two different things, seem to be much, much, much lower in patients with restless leg syndrome than in patients with chronic pain. And very frequently, these doses stay stable for decades. So this is a nice publication out of the Johns Hopkins group. And this is about 10 years. Okay, so 4,000 days or so. This is, the first one is pergolide, which they used to use, and then pramipexole, and then methadone. Now, methadone is a very popular opioid for the very reason that it is especially non-addicting, and it does not give anyone much of a buzz. So no one really feels good on methadone. It has some differences. It's not quite a pure opioid. It doesn't seem to increase dopamine in the ventral tegmental area, which is why it's thought not to have addictive properties, and why it's used to get people off of other opioids, because it does prevent the withdrawal symptoms. But again, no one really feels that good on methadone. So you have here, this is, again, survival on drug. People in the first, couple of months, a bunch, whatever, 10, 15% drop out for various immediate side effects. But after that, you get this sort of linear dropout with the dopamine agonists over time. And this is usually from augmentation. However, if you're on the methadone for 3-4 months, no one ever dropped it. Okay. And most importantly, okay, well, they didn't drop it because they're addicted to it. You might say no one went up on the dose. In fact, the actual mean dose, if anything, goes down slightly over time. So this is a mean dose of 10 milligrams in this study. That's a very, very small dose. That's like a 1.5 morphine equivalent. Okay. So a very, very small dose of an opioid. So again, this is kind of our fallback drug these days. Is methadone. It's still a bit of a hassle to use. There's certainly dogma associated with chronic use with methadone. People look at them funny. The pharmacist doesn't like it, but it can be extremely effective. And we did publish a paper now about 1.5 years ago on what we consider the appropriate use of opioids in Mayo Clinic proceedings, if anyone wanted to look at some of the data, again, supporting that there seems to be very little addiction and very little dependency in this population. All right, next big class of drugs. No one's ever come up with a catchy name for these. The alpha-2 delta subunit voltage gadolinium channel family. Most people just call them the gabapentin-like drugs. And there's really only 2 of them. There's gabapentin and pregabalin. Now, I'm not sure if this is available in India or not, but gabapentin anacarbol is a drug that's actually the only one that's approved by the FDA for treatment of restless legs. Now, these are kind of interesting, these receptors. They're part of voltage-gated calcium channels, but they bounce around on different channels. So they're not all on T-type or on P-type. They're just a subunit that seems to attach itself to some channels. Now, where they're found predominantly is in the spinal cord and in the thalamus. So they seem to be found very much in the sensory afferent components of the nervous system. And when you stimulate these, the bottom line is you end up inhibiting the release of glutamate. So these are on glutamatergic cells. And if you stimulate them with a medicine like gabapentin, it turns out you're actually reducing glutamate transmission. So again, gabapentin, I think as most people know, has nothing to do with GABA, even though it kind of looks like it has no affinity for GABA receptors whatsoever, but it's actually a glutamate in release inhibitor is how these drugs work. Now, like I said, gabapentin anacarbol is the only drug that is actually approved in the United States. And basically, they took gabapentin and added this 5-carbon chain so that it's absorbed much better. The big problem with gabapentin is it's a lousy pill. There's tremendous variability in how people absorb it. And some people don't absorb it very well at all. Which is why there's a tremendous dose range in gabapentin. Gabapentin anacarbol is absorbed linearly. It's absorbed almost passively. Even in the colon, you absorb this. So it's just better absorbed, and then it becomes gabapentin in the blood. Now, there is one big trial comparing this class of drugs to a dopamine agonist, pregabalin versus pramipexole. I will say this was sponsored by the makers of pregabalin. Which was, again, Lyrica at the time was the brand name in the United States. And I think there's a little bit of bias in the design towards that. They used a very big dose of pregabalin and a relatively small dose of pramipexole. There was 2 parts of this. There was an acute phase and there was a chronic component. In the acute phase, the pregabalin actually improved the IRLS score a little bit more than did pramipexole. However, there were also more side effects. You had a higher dropout rate in the pregabalin group compared to the pramipexole group. What they were looking at long-term was augmentation, because the idea is that augmentation has been specific to dopamines. So they can carefully look for augmentation as populations. So they got drug, they got better. And towards the end of the study, at 40 weeks late, they were doing worse and had an earlier onset symptoms. And by that definition, they had only a 2% rate in pregabalin versus a 5 and a 7.75 rate in the higher dose pramipexole. So it does support, which I think we all believe, that the real hardcore augmentation we see is a specific dopamine response, and it is an argument for not using those medicines in at least an earlier disease. So we compare sort of the two first-line treatments, the alpha-2 deltas versus the dopaminergics, because I don't think anyone considers opioids a first-line treatment for this population, although, again, they are readily available and they do work very well. The dopaminergics probably are better at getting rid of the leg kicking. And anecdotally, because it's just hard to quantify, if the patient describes a pure urge to move, I mean, it's just urge to move and there's no pain, nothing else, I think that dopaminergics are extremely effective. However, the alpha-2 delta drugs have their advantages. They're better sleeping pills, and they don't knock you out like a benzodiazepine, but they actually increase slow wave sleep. So they improve sleep architecture. There's very few medicines that actually do that. So they have some advantages in general. They also improve pain. So this is not a vacuum. Someone may have RLS and neuropathic pain or some other back pain. So you might get improvement in two things with one medication. And again, the main argument long-term is there seems to be the less augmentation. All right, so again, both of these are considered first-line drugs. I think there are some reasons to use one versus the other, but I don't think anyone will sit here and tell you that one is definitively better than the other. All right, last treatment. Iron. Well, why don't you just give iron? Okay, we've shown that the pathology is iron. We don't really know if that's causal. I mean, it's there, but we don't know that that's causing the symptoms. To be technical, it could be a epiphenomenon. Nevertheless, iron is a potential treatment that we would consider. The problem with oral iron is that it just doesn't work very well. Oral iron are in salts, okay, and the body does not absorb iron salt. So here's a 30-second review on iron absorption in the gut. So over here is your gut, and this is blood over here. So there's a couple of different types of iron. So if you have iron in heme, okay, blood, this is absorbed very well. Okay, so there's special heme transporters that absorb the whole heme molecule into the cells around the small intestine. However, if you have iron that's free in salts, you don't absorb it as very well. So first of all, ferric 3+ iron doesn't get absorbed at all. It has to be actually oxidized to 2+ iron, where it's absorbed through this divalent metal transporter. Now, this competes with other divalent metals. So calcium, for example, goes through here. Magnesium goes through here. All right. So you have to have 2+ iron, and then you have to have enough availability of these to even get it absorbed. Okay. Now, the journey is not over, because once you're in the cells, there's a second regulatory agent, ferroportin. It has to go through ferroportin, this is the 2+ iron now, to get into the blood. And ferroportin is inhibited by hepcidin. So people with mutations in hepcidin, you remember, have hemochromatosis. They don't inhibit the ferroportin, and iron pours in. Now, not on this slide is ferroportin is also inhibited by ferritin. Okay, so if the ferritin is probably over 50 to 70, probably 50, you basically block the absorption of oral iron. So if you have someone with a ferritin of 100, I mean, you can give them all the oral pills of iron in the world. You're not going to do anything that can make them constipated because they're not going to absorb it. Okay. So again, there are some tricks. Again, in a vegetarian country, there's going to be a lot of iron deficiency. I mean, iron deficiency still is the most common nutritional deficiency in the world. If you want iron pills, there are some tricks. First of all, it's best if you're iron deficient. If your ferritin's high, you won't absorb it. The best source of iron is heme iron. Okay, then the ferrous 2+ iron. Many iron pills come with vitamin C to acidify it to keep this stable, because again, this goes back and forth between 2+ and 3+ non-enzymatically. You also need this divalent metal transporter protein availability, so you do not take it with milk or a multivitamin pill. So iron with a multivitamin pill that has magnesium, also a waste of time. So you have to take it basically on an empty stomach as well. So these are things that can improve the absorption of oral iron if you're going to use it. So that being said, we've generally switched to intravenous iron because it doesn't matter anything. When you give iron by vein, you're going to get a huge amount of iron in your body. Now, I have a bunch of slides here, which I'm going to kind of blow through to make a couple of points. This is, I think you're recording this, and if you want, this is my summary slide of different intravenous irons. The key here is the ones that work the best are larger atoms. And if you look, the one that doesn't work, bottom line, is iron sucrose. And this has been shown in a couple of studies not to work. There is one positive study that showed benefit, but what I really recommend is do not use iron sucrose. The ones with the best data are the low molecular weight iron dextran and then ferric carboxymaltose, but other ones probably work well as well. So this is the ferric carboxymaltose, which has the best data, and this is trying to get approved in the United States as an official treatment for restless leg syndrome. And again, don't worry about all the numbers here. The majority of studies show significant improvement in RLS, and the ones that have looked at leg kicking with sleep studies also show improvement in periodic movements of sleep, which is something we like because it's quite objective, okay? Couple points about intravenous iron. Need big doses, okay? These are big doses, and if the place is not used to this, they are not used to these doses. This is much bigger than someone on dialysis gets, because what you have to do is push it into the brain. And iron in the brain is, a bit risky because it's generally thought to be a bad thing. But if you just give 100 milligram doses like you do with dialysis patients, it doesn't get pushed into the brain. So again, you really do need to give a single huge dose of this, all right? The maximal efficacy is delayed. It always takes a few days, but in the studies, in the blinded study, it's about a month out that patients had their best benefit. And these studies have been very, very safe, very little actual side effects, very little risk of high ferritins. I mean, that's a theoretical concern because I sometimes push ferritins 600, 700, 800, and people get worried about that. Just nothing has come up that's caused liver damage or anything along those lines. Okay, so with that, I'll wind it down, and my concluding remarks. I mean, again, very, very common condition. I said about 2% in India. It seems to be the best literature out there. It's a diagnosis based on just interviewing the patient. There's nothing else you need. I would recommend iron tests if at all possible. Pathophysiology is there. It's not a disease that doesn't have any physiology. And although there's no cure for this, usually the treatments are really quite good. And your goal really should be 90% improvement in the symptoms. Okay, so that is the end of the lecture. I'm going to stop sharing, and I'm not sure if there was questions or not.
Lots of questions, Bill, and that was an excellent overview of RLS in the shortest possible time. The least addressed a movement disorder in India, at least. I've got lots of questions. One of the questions that people have asked is, why is there a diurnal variation in RLS?
Well, not entirely known, okay? There are certainly some correlations. I mean, it goes along with other circadian factors. And there is...
you will have to enable or make me the host. Again, Pramod is no longer able to come because you became the host. Mansi is not there, so we have a little complication. Make me the host, then I will do other things. Click on me, click and make it host.
Okay, I have to make you the host. Okay, fine.
Sorry, William, to interrupt. Click on the panelist, Sudhir Kothari, and make it host.
Sudhir Kothari, make host. Yeah, got it. Change host.
Okay.
Yeah.
Go ahead.
Yeah. So the diurnal variation in RLS that you answered, how do you treat RLS in pregnancy? That's what people wanted to know.
Yeah, well, certainly folate, and certainly if there's any suggestive iron deficiency, you would treat it with that. Although, like I said, ferritin goes up markedly in pregnancy, so it's very difficult to assess that. The dopaminergics have never been studied in pregnant women. We don't know how safe they are. There are some opioids like codeine, which are generally considered to be safe in pregnancy. So in very severe cases, that's probably actually what is used, the opioid medicines that have been used for many, many years in pregnancy. Many women, understandably don't want any new medicine because it will improve, shortly upon delivery. But we don't have anything that's really ever been studied in pregnancy. There's no data there at all.
There's no data at all. And what's the duration of the treatment in RLS?
Well, I would say the vast majority of people, when they get it bad enough that they need treatment, continue to treatment. I mean, I've had very few people that have ever come off treatment. The exception is sometimes the intravenous iron can work well enough that they can get off other oral medications. Now, that being said, earlier in disease, it can wax and wane, and patients may have RLS for 6 months and then it goes away. But it's pretty unusual to have bad RLS every day for 6 months or a year and then have it just resolve the next day. That's pretty unusual. So I don't have that many patients that have come off treatment once we've started.
Okay. And how do you switch the dopamine agonist? How often do you have a regime, or you do it only when augmentation comes with one dopamine agonist?
I don't do it. If they're doing fine on a dopamine agonist, I don't think there's any reason to change. So we do it when patients are doing less well. Pramipexole has a longer half-life than ropinirole. The Nupro or retigatina patch, of course, is close to 24 hours. So some of it's just pharmacokinetics that are different, but we don't have a schedule. So if someone is doing badly on ropinirole, you may change the dose of ropinirole, or you may switch to pramipexole, but there's no formula I have for that.
And a little bit about restless arm syndrome. When do you see it? Do you see it in isolation? Do you see one leg involved with RLS? Those are the questions that have been asked.
Well, again, arm involvement is common in the setting of augmentation, and if someone has had 30 years of RLS. So, they may have 25 years of just legs, and then they start to get arm involvement when it gets severe. I said there's a couple of case reports of restless arm syndrome. I mean, it's really, really, really rare. I haven't appreciated any difference in the treatment responses if they have an arm involvement or not. And again, almost always it's bilateral to some extent, although one side may be worse. And it's not uncommon to alternate one night the left leg, another night the right leg. You hear that all the time in patients with restless legs.
Okay, and this is from Pankaj. The role of tramadol, and where does the morphine, why are the several RLS gene not associated with the transcellular iron transporter? What is the role?
Correct. None of them that I know of. And again, there are a slew of GWAS genes that haven't been published yet. But to my knowledge, none of them are iron transporter. RLS3, the linkage area is right on iron regulatory protein type 2, and we were sure that was going to be it, but we could not find a mutation in that protein. So still, there's no gene that clearly explains the reduction in iron that we found at this point.
And he's asked the question: where do opioids act? Do they act centrally, or do they act in the spinal cord level?
I don't think anyone can answer that. I mean, I'm assuming they act in predominantly in the thalamus, but I don't even know a way to prove or disprove that.
Putting somebody on opioids for restless leg would be pretty dangerous, knowing that it's a long-term disorder, and getting them off the opioids would be nearly impossible once they get onto it.
I would say getting them off dopamine agonists is much, much more difficult than getting them off opioids. Because anytime you stop the dopamine agonist, there's a marked exacerbation of restless leg syndrome. Whereas with the opioids, like I said, they don't escalate the dose. It's very different population than chronic pain. The chronic use response is very, very different than what you might be used to with someone with back pain or things like that. I have almost no one that I've ever increased the dose after 6 months of methadone. So yeah, I mean, like I said, there's legitimate concerns with chronic opioid therapy, but I think if anything, this may be underused in people with really severe restless leg syndrome.
What about caffeine? caffeine and aggravating restless leg syndrome?
It's always on lists. I really don't think it's that much of an issue, as are sleep hygiene. So, good sleep hygiene is often listed as a treatment for restless legs. But to be honest with you, good sleep hygiene probably worsens RLS, because anything that makes you tired or relax tends to worsen the RLS. Alcohol frequently can worsen RLS, okay, as can really anything that relaxes you. There are people that drink to pass out when it's very severe. So you still can pass out with alcohol, but very frequently patients will say that, one or two drinks will actually worsen the restless legs, and they often don't drink because of that. I'm less convinced that caffeine has much of a role.
I had a patient who said she could not watch a movie inside a theater because she could not sit in the seat, and often she would go and stand at the door and watch the movie from there. And after giving her intravenous iron, she was so happy. She said, for the first time in 20 years, I could watch a full movie sitting in the theater.
Yeah, great. Intravenous iron, it doesn't work all the time, but it's really, if you have access to it, it's a really pretty simple thing to try. And it's like a one-time treatment, and it could last for years. And then maybe 3 or 4 years later, you might do it again. So it's certainly something that's I would say probably 70% of my total patients now get intravenous iron.
And do you repeat the iron in these patients, or it's one-time dose?
The iron will go up for a couple of years with the one big dose of iron. And that's where I can't say there's much data to go on, but we rely more on the symptoms than the numbers. Now, that being said, if someone already has a ferritin of 500, even I'm not that comfortable giving them another round of intravenous iron. But I am comfortable at, 200. That's still in the high normal range. We will give a second round if they responded, and then 2 years later, they're doing badly. To me, it's more dependent on the symptoms than the numbers.
There are 3 questions. Is there any association of RLS with one migraine? There is akathisia and obsession or OCD.
There's been at least one study which showed some association with migraine, but there's a number that haven't. If there is, I think it's pretty minimal. Okay. Other than women are more likely, I don't think I mentioned this the whole time, but women are certainly more likely to get RLS. Women are more likely to get migraine as well. Akathisia, RLS is a form of akathisia. It's a focal quiescogenic akathisia, circadian akathisia. It's an urge to move. But we think of, when I think of generalized akathisia, I think of dopamine antagonist medicines. So it depends. It's just a matter of semantics, whether you think there's an association there or not. And I'm sorry, what was the last one?
OCD, obsession.
Oh, OCD. Anecdotally, I haven't seen that, and I can't recall a study that, other than a written questionnaire, has shown that. There have been a lot of epidemiologic studies, and RLS is so common. If you go through the literature, there's a huge number of associations. Just a huge number. And many of them will, be looking at that disease, and they'll say, well, 5% of these people had RLS, and say that's an association. Well, that's the normal population. So I sort of emphasized the associations I thought were more robust, but there's 20 or 30 in the literature associations with RLS.
The common link to OCD akathisia is an urge to move, which is again similar to RLS. That's
RLS technically is an akathisia. It's just focal, circadian, and quiescogenic. So it's akathisias. Even when they move around, they still feel it. It may improve a little bit, but it's still there. They want to move, but it doesn't necessarily make it better as much as the movement does with restless leg syndrome. But yeah, they're dopaminergic-ish conditions. There's clearly some relationship. Yeah.
And last question is almost a second last question. The management of RLS in PD who are already on a very high dose of dopamine. So how do you manage it in PD who are advanced?
Well, again, there's no data. if they're not on a dopamine agonist and it's a possible option for the PD standpoint, I mean, haven't had psychosis on it or there are various reasons you don't use dopamine agonists, you still might consider a dopamine agonist, because I think dopamine agonists honestly are a little more effective than levodopa. I don't usually see much role for increasing dopaminergics in general. So if they're already on levodopa, I don't think more levodopa would help. And we use gabapentin type drugs in that population. If you give them just at night, they're well tolerated. You know, they don't cause balance difficulties the next day if you just have like gabapentin at nighttime. I rarely have used opioids. I don't know if I've ever used opioids in that population because they're already constipated and they already have cognitive issues, and there would be a higher risk in that population. So, you know, again, the gabapentin type drugs or maybe a dopamine agonist. And iron, you know, this is a scenario where I have not ever given intravenous iron because, of course, in PD, we don't know this for a fact, but we think brain iron is potentially accentuates the disease or propagates the pathophysiology of PD. So I wouldn't give high dose intravenous iron in a Parkinson patient, period.
Particular cohort of this. And propranolol in RLS, that's one of the questions. Do you use propranolol?
I have not really used propranolol. I mean, I didn't show, I do think there's some association between tremor and restless legs. I didn't show that slide because it's our study and no one's ever replicated it. But I haven't really used propranolol in RLS. I know there was some open label, you know, from like the 1980s, or I think one open label study on propranolol, but I just haven't used it now.
Okay, the last question now. When the world is moving against eponymous syndromes, why is RLS Foundation still calling it Willis-Eichbaum disease?
Well, they actually officially went back to restless legs. The issue was they thought it trivialized the disease. The name, you know, was sort of a trivial restless, you know, legs. And that was the rationale to going to Willis-Eichbaum. Eichbaum was a Swedish neurosurgeon who described in the 40s, 50s, and 60s, described a number of series of RLS and actually treated with intravenous iron. And then that was forgotten for decades before it sort of came back in the 90s. So he was way ahead of his time. But that's the reason. They felt that the name trivialized and people made fun of the condition. So but they did actually officially, it's back to restless legs.
Good to have you back,